Good afternoon, everybody. This is the clinical session, breakout session, aligning the silos to integrate chest CT health information. The title, by the end of this, hopefully we'll have a better title for this session along the lines of creating integrated accountable care for chest thoracic health. And with me is Dr. Mary Pasquinelli, and I'm Bruce Pyenson, and welcome to our session this afternoon. Could we have the first slide up? No, not yet. Oh, we do. There it is. Let's go to the next slide, please. So we're going to have a straw dog session and try to design a system that combines the attributes that we've all been talking about through the day of comprehensive care through a lung screening program or a thoracic health screening program that includes cardiovascular health and lung health, and how that can work, especially in the U.S. Medicare program. Being U.S., apologize for being U.S. centric, but we're using that as an example because that's a program that focuses on the population that's probably most at risk, an older population that includes a significant number of people with disabilities. So we're going to go through a straw dog exercise, and we're going to hold a competition of who can guess the kind of dog we end up with at the end of this. So write down your suggestions in the chat, and whoever gets it right is going to get some the half of the bowl of chocolates that's here. But can we go to the next slide, please? So just a couple of characteristics for this thoracic health program that we're thinking of, and we're going to try to design. And this is not quite pie in the sky. We're focusing on a program that can actually be scalable and implementable through the payer system in the U.S. for an older population. And a few of the characteristics, I think these are some of the things we have to define here in the course of the next hour are listed. There's lots and lots of detail. Obviously, we're not going to be able to produce all of the details, but we need a clinical model that captures the kinds of services and coordination of follow-up and patient flows that we know to be important and represent a quality program. We need to define populations, partly for accountability. You know, the population can't just be people who show up for screening. Population has to be, for example, the 60 million people who are covered by the Medicare program, or it could be the population of the country, Croatia, Poland, national system. We need to define accountability, not just what an organization is accountable, but what is the organization? What is the entity that's actually responsible for running a program, probably on a local or regional basis? We have to make some progress on have some ideas of the financing for this. Today, a lot of the organizations that are doing lung screening are doing it in order to generate revenue for the sponsor. And that can work today, but that's probably not an ultimate solution. Ultimately, organizations have to live within a budget and have to produce outcomes. So generating revenue is important, but being a part of a budget and generating value into that is probably what's not viable. But before we jump in to working out some of the details here, I'm going to ask Mary to describe her hybrid system that she's running today, because I think that's probably one of the best examples that I've seen for this kind of program.
Yes.
So if I could hand over the virtual microphone to
Yes,
you.
thank you. I'll take that, thank you. So I'm Mary Pasquinelli. I'm the director of the lung screening program at the University of Illinois in Chicago. And we kind of think about lung screening models as being centralized or decentralized or hybrid. And I would kind of classify ours as a hybrid. But I want to kind of get away from that and think about it as, it doesn't matter which model you go with, a centralized or a decentralized, each one of these are going to need different resources and different structures around them to be sure that everything is being done for that patient getting screened. So what we do at UI Health is I run the nurse practitioner-led lung screening program. Primary care doctors can either screen patients on their own and go ahead and have them scanned and they follow up with results, or they can send them to our lung screening clinic, which is ran by the nurse practitioners. And we do everything from A to Z with that patient. So they come in and see us, we do the shared decision-making, we do the smoking cessation, and we follow that patient to be sure that they get everything done within that framework. We also have those discussions about incidental findings. We also talk about their health behaviors that increase their risk for lung cancer or lung disease. But then also, why I call it a hybrid model, the patients that aren't seen within our clinic, I still oversee the whole program. So I want to be sure that even the patients that didn't come through our centralized program, that they're having follow-ups for all of the scans that they need to be done. So we have kind of a system in place with lung screening coordinators and navigators to be sure that a patient that needs a scan in 3 months or 6 months or 12 months is getting those scans. The other thing as I do at our program is any patient that has a concerning finding, a lung RADS 4, I talk to the primary care directly about that patient to be sure that the patient gets the care that they need. We present those cases at our multidisciplinary tumor board, and then we follow those patients. The majority of time, the primary care doctor will send the patient directly to us after they talk to the patient about the scan results, and then we follow it from there. So I hope that gives you kind of a bigger understanding of our program.
That's terrific. At what point do you release the patient, if ever?
So the patient either can come to me at the very beginning when they are starting to get lung screening. Then we follow them every year until they either, sometimes people move, sometimes people have changed in status where maybe a lung screening is not appropriate anymore. Or sometimes the patient is diagnosed with cancer. And when they're diagnosed with cancer, they come to see us in the pulmonary clinic. Usually we order the biopsies either through EBIS or even a CT guided biopsy. We be sure that those patients have those results. And at that time, when we have that meeting with our patients, we have our lung navigator, who's an RN, comes and we have kind of a team approach to be sure that patient is supported in order that patient to get transitioned into care for a thoracic oncology diagnosis.
Thank you. And the reason I was asking for the duration or the end of an episode, for some patients is that we're heading to defining a bundle of services for this thoracic health program. And the bundle has a start and an end. This has a annual cycle. And I think that's important for both the clinical model as well as the financial model and the accountability. Because all of that is the responsibility or the accountability of the program. could we have the next slide? Please. Thank you. So as a hypothesis, I want to suggest that collecting the various services for integrated thoracic health isn't going to happen if it gets organized on an ad hoc basis. That is, if a health system encourages lung screening and encourages the follow-up of other important findings, without a way of tracking the patients and making sure that everything that needs to happen happens, it's not going to happen. This is not a matter of motivating physicians to keep doing more of what they're doing. And I think that's a recipe for demoralization and burnout. So instead of that, whether the program operates under one roof or is virtual or a hybrid or whatever, there has to be the accountability for the entire process, and it needs to be seen as an entire process. An example of that, which has been very successful in the US, has been the bundled payments for hip and knee joint replacement. And that's operated by private insurance, but mostly by the Medicare program, which includes the workup for a hip or knee joint replacement. It includes the surgical stay, inpatient or hospital outpatient, as well as the professional fees, the cost of the implants or the joints, as well as the post-acute care. That's been something that's been going on for about 10 years in the US, and the cost of those programs and the outcomes have improved dramatically. Cost has gone down, the outcomes have improved. And the physicians and other organizations participating in that are actually very happy with the results and their participation. So this kind of pulling things together has been proved to work in this case and other cases, but the straw dog is to create something like that for thoracic health. So some of the elements we've talked about is that, you know, the screening, patient navigation, clinical information, the follow-up, the referrals, all of that is the patient journey, and the accountability for that, it would belong under this program called Thoracic Health Program. That's a name we came up with, THP. I'm sure there's better names. A challenge we have today with any of this, and this has come up repeatedly in the discussion of QIW and IOCAP and Agile and other conferences, is the siloed nature of the healthcare system, certainly in the US, but also in other countries, where the patient might have something identified, they get referred to, you know, endocrinologists, they get referred to a pulmonologist, they get referred to a cardiologist, and perhaps lost the follow-up. Perhaps the patient never gets seen again, but it's that loss to follow-up is something that we see over and over again, even in lung screening. In the data that I've looked at, the repeat screens are dismally low, on the order of 15 or 20% in the Medicare program, which means that that makes it even worse when we're seeing 10% of people getting screened. There's very few people who are getting the regular annual screening in the Medicare program. So having the accountability for not just the outcomes, but the consistency and the repeat would be the responsibility of THP. But when we think about a program like this, we have a challenge compared to other episodes, like I mentioned, hip or knee joint replacement. There, it's an acute event. It's very intense. There's a lot of services, and it gets done. A challenge with this program is that the vast majority of people really don't need much follow-up and are healthy, at least on an annual event. And that means we have a small number of people who need intense follow-up, a number of people who might need some follow-up, but most people don't need any until the next annual screen. So we struggle for analogs. One of them might be the childbirth episode, where most deliveries and prenatal and postnatal care are routine and nothing bad happens, but some of them can be very intense. Let's go to the next slide. So a concept as we build this straw dog is to stratify this population of screened people into their segments, and recognizing that, as mentioned a little while ago, I'm using about 95% are get screened that are good to go. Maybe it's a little less than that if we're looking at COPD, emphysema, cardiac calcification. But I think in the initial screen, maybe only 5% or 4% of people need a subsequent CT scan to follow up on nodules. So the vast majority of people get screened and sent on their way. No real follow-up needed. And
1 year annual follow-up.
1 year.
So your lung reds 1s and 2s, yeah.
And so and maybe if we're paying attention to coronary calcification, the evidence of emphysema, maybe that goes down a little bit. But those individuals don't require much resources, so therefore they're going to bring in. They're not going to cost very much. Now, there's in the remaining 5% or so, I've broken out 3 different sub segments.
It's more than 5%. The initial baseline, it's some places report 20%.
Yeah.
So 80% would need an annual follow-up.
Yeah.
Of the initial screens and the
And then it's better on the annuals.
second.
It's between 5 and 10%.
Oh, okay.
On each subsequent annual. And those are almost always nodules, findings on both of them. Majority of the findings that require follow-up CTs are related to nodules or something else in the lung, a pneumonia or something.
And probably the calcification isn't.
It doesn't lead to the annual follow-up CTs.
Yeah, and it's not an annual finding, right?
Not yet.
Yeah.
Not yet. I mean, that's the dream. That there's going to be progression, evaluation, and that sort of thing. But that's where we think the field is heading.
But let's talk about the whether it's 10, say 10%, the remaining 10%, what happens? Some of them are there for the lung nodules and lung rats and the follow-up from that. Some of them are high risk for other lung disease. And
They're not getting follow-up CTs for that.
no, they'll get follow-up. Won't be a follow-up CT. It'll be there'll be some protocol for how those individuals get followed.
Yeah.
And there's gonna be spirometry, there's gonna be, you know,
Something.
lab tests and so
Blood
forth.
tests, lab tests.
And likewise on the coronary calcium, there's gonna be prescriptions
Yes.
and so we have, you know, I've created 3 different groups of follow-up patients. Maybe there's more, maybe we need to split out those into high risk and low risk. But that's a way to think about the population of this thoracic health program. Because again, we're dealing with a population, think of a, you know, million people. And out of those million people, maybe there's, you know, 10,000 that are going to come through this program in a health system. So the next step is to drill into more detail on that. Let's go to the next slide. So again, the biggest group of people here are no follow-up until the next annual screen, and that's typical of most populations. You know, in Medicare population, maybe, you know, there's a good portion of people in a Medicare population who don't get any care, any significant care in a year. In a commercial population, you know, it's only about 5% of the people who go to a hospital in a year, and the biggest portion of them are maternity. So the THP is mostly taking care of people who are probably pretty healthy. But it's the remaining 10% that are where the management and the effort comes in. So I've listed some of the potential workup here. And again, I suspect a lot of the workup is heavily concentrated in the first round, where people who have coronary disease that's undiagnosed get discovered, and likewise with pulmonary disease. Now, I haven't seen a lot of statistics on the portion of people who are undiagnosed who get diagnosed with emphysema or coronary artery disease through lung screening. I think ILCAP has published some on that, but it's
I think those numbers are going to start to. I think there are going to be a few things that are going to become much more prevalent. You know, I think osteoporosis, for example, is going to become a much bigger deal in the lung screening population very shortly, because of the sort of DEXA equivalent now that's happening. I mean, I'm already seeing, you know, we're just starting to run it. You know, we rarely call osteoporosis on a low dose scan, even though we could. Nobody wants to take the time to measure it carefully, and people are just not. But now that it's all being done automatically, and the numbers are high, I mean, some 30 or 40% people have osteoporosis.
But what's relevant for population health is not what portion have osteoporosis, but what portion haven't previously.
Well, I'm saying they don't know. They don't know.
Well, they may not know it, but that might have been diagnosed. If you ask the patient, they may not know it. They may have been diagnosed.
No, I think that their doctors don't know it.
Their doctors don't know.
Yeah, I'm pretty sure. Because they would have had to have a DEXA scan or something. They're not. Percent of people that have DEXA scans is still relatively low, even in the screening population.
And DEXA scans are
That's
not
the standard osteoporosis.
yeah, it's that the U.S. Preventive Services Task Force. The DEXA scan indicated, I believe, for women only as a general scan. It's not unless there's a reason for a man to get it.
I don't recall. I think it's recommended for anybody over a certain age.
Yeah.
Anita is checking. Maybe we'll check.
Anita's looking it up.
Anita's
And
checking.
the star metric is for women who've had fractures to be considered for therapy. That's the star metric.
I mean, it's reimbursed for
interesting.
women over
Yeah.
a certain age. Or some definition, postmenopausal, or something like that.
So that sort of interaction, I think, since we're focusing this on a Medicare program,
Just one.
Women age 65 and older.
so does that mean that a screening program should identify osteoporosis only in women? If that's the Medicare policy.
It's an interesting question. It goes back to the first sessions we had. Right?
There's a difference, though, when doing it in an age over 65, if you're suspecting it in women, gets covered. However, if you find osteoporosis as a diagnosis,
Right.
that changes the situation.
Right,
Now it becomes a covered diagnosis.
right. Interesting.
At least that would be my understanding.
Oh, that's right.
So covered, when you say covered, what would?
So if they need the next step, if they have to see
Well,
an
the next step.
endocrinologist, if they get drugs that
Yeah,
it'll qualify them for coverage under that diagnosis.
yeah, and I assume men too would be covered.
Right, if the diagnosis is vague.
It's always so interesting to me that they'll pay for it if you have it, which means it's worth knowing about it,
Right.
but they won't pay for looking for it. It really doesn't make any sense.
But
Here can use the screen to do
Yeah.
all that.
But I think working out that sort of detail is something that THP would need to do. As now, I want to pause a little bit and talk a little bit about accountable care, and especially for folks who are might be staying up very late in Europe. The U.S. Medicare is the socialized medicine program for people over 65 and people who meet certain disability characteristics. Virtually everybody is covered by it, or over 65 or disabled in certain ways. That program is split about half and half between what we call the traditional Medicare, where the government is literally the insurer, and a privatized version, which is called Medicare Advantage. And it's about today about half and half. There's some discussion that it should all be privatized. And then there's some other discussion that says the Medicare, the private second side of this is doing a lousy job. So they should be, that should be moved over to what it was originally. It should be deprivatized. But that said, these are population programs, so are ideal for the kind of public health, population health, and in total cover about 60 million people. Within the original Medicare program, Medicare has established what are called accountable care organizations, which have people assigned to them. The accountable care organizations are mostly medical system operated hospitals. There's some that are run by physician groups. And those cover on the order between 10 and 20 million lives. And the Medicare Advantage plans, which are insurance companies, cover about 30 million lives. So we have a basis for payers assigning outcomes to a population. And if it's an accountable care organization, they in effect have lives and can be held and are held responsible for the outcomes and the budget of those lives, as are the private sector of the Medicare Advantage plans. So I think we can take this THP idea and propose it to the Medicare program to actually operate as a subset of both Medicare Advantage and accountable care organizations. And say that they will keep track of the performance and create financial incentives and standards for THP to operate for the majority of people covered by Medicare in the US. And so what we're building up here in this straw dog is a proposal to the centers, the Innovation Center of Medicare. It says, hey, here's a opportunity to make a huge difference for lung cancer, for heart disease, for lung disease within the existing structures of the payment system. And what we need to do is set up those 4 criteria and in a way that can design a program that could be operated locally or could be operated by one of the Medicare Advantage plans. So if we go back 3 slides, I think, please. Yeah. So the clinical model saying that if we're successful in convincing CMS, they will promulgate a program that defines a clinical model. Here's the services you gotta offer and the coordination. And it could be under one roof or virtual or some hybrid. The population served would be, a high-risk population, probably the eligibility for lung screening, hopefully expanded. The accountability would be either the accountable care organization or the Medicare Advantage plan. And the financial model would be perhaps some seed money, but the financial model would be say, well, we're going to keep track of your performance. And if you outperform the baseline, we're going to give you extra money. So we're going to define these 4 kinds of criteria and as our straw dog, because that's what the Medicare program would have to come up with in order to promulgate this program. And again, we're talking about people, roughly 45 million people in the US. So this is a big jump ahead. We could go back to where we were. So we need a lot of details to make this thing work, and then thinking about who the patients are and what kind of care they get and what are the services that are responsible for THP and what are not. And some of the things, the challenge for Mort or others on for example, on the coronary calcium score, how do we think about people who come into lung screening who are already being treated? How do we think about people who are not being treated? And where does responsibility for them lie? We're not going to be able to take those people already treated and pull them in, or maybe we can pull them into THP. So there's a lot of details to work out here in this comprehensive program. But I think if we try to do this integrated heart lung screening of this high-risk population, if we don't have it accountable in one place with the kind of coordination that Mary described, I don't think it's going to work. I think it'll be overwhelmed by the silos that we have, and patients will get, we'll identify some patients, they'll get scattered to the wind, and we're not going to have the kind of outcomes that we hope for.
Bruce, I totally agree with you. I'd love to share a comment that Vicki gave, because she had to leave for a flight, saying, Mary, who ensures that patients are being screened outside our nurse practitioner program or receiving the same quality of care or protocols based on following up on those screened through the nurse practitioner pathway? How are patients tracked who are screened outside your program? Would it not be better to integrate into one screening pathway and eliminate screening into silos by primary care? And what's interesting that happened in the development or evolution of our program, first we started the program in 2015. And at that time, they could either refer to our nurse practitioner program or they can do things on their own. And what we found is the primary care doctors, we have FQHCs, we have resident clinics, we have fellows running clinics there. It's kind of, and then they leave, they go on their next rotation. So there was a lot of fractures in the program. And some doctors, were great with following up and some were not. And what was happening, the patients, let's say the lung RADS4s that needed biopsy, the primary care doctors would sometimes send them to IR guided biopsy, or sometimes to pulmonary to have an EVIS. Sometimes they'd send them right to thoracic surgery. Some of them would do a medical oncology consult. So they were being all over the place. And when you get a patient that shouldn't go to thoracic oncology, they should really, or shouldn't go to IR because they have some mediastinal lymphadenopathy and they should have an EVIS, it starts to delay care and hurt outcomes. And so what we did with that, and then kind of going along of how you're doing this or proposing to do this, is that our lung screening program took over the process. So all lung RADS4s are nurse practitioner to physician decided upon. So to be sure they got the right biopsy or the right diagnosis or to the right person. And then we were able to expedite all of that care. So we're starting to kind of use this model, although we're not getting paid for it under Medicare, but we're doing it because it's the right thing to do for our patients. And that has really improved our care and also our return rates for our lung screening, now that our program has taken over all the 1-year follow-ups, is we're up to 90% of patients coming back for their screens. And we serve a mainly minority population, low socioeconomic communities, low education. So if we can do it in this population, people should be able to build a structured program that can improve outcomes for whatever program that they're doing. The one thing we haven't done is really kind of diving deep into the coronary artery calcification and the emphysema. We do that when we see the patient, we talk to them about the results. When they come to see me, if they do have coronary artery calcification, I double check to be sure that they're on a statin. If not, I talk with the primary care doctor. But I think even integrating this more will really improve outcomes even more. So I'm really more of a strong.
I make a comment.
Yeah.
I agree, that's an ideal model. I think it's not gonna work everywhere. In fact,
It
it
won't.
probably won't work in most places because of the community, the relationships physicians have, the administration in the hospital, how many hospitals are in an area, competition. But I agree with what you're doing is exactly right. The other question I have for Bruce is, if this is gonna be bundled, doesn't somewhere along the line you have to show that by paying for this, you're gonna improve outcomes? So if osteoporosis, you pay for that, are they gonna have less fractures? Accordingly, there's some studies that show that happen. Are they gonna have less MIs if you treat the coronary calcification? Are they gonna have less hospitalizations for COPD if you diagnose emphysema and treat it earlier? Do we need to show that at some point? That's the not the pharmaco, that's the economics of improving care that will justify paying for the preventive costs up front.
Yes, I'm envisioning this as a slight modification to the existing accountable care.
Okay,
So, so if Christiana has an accountable care organization, and under the context of that accountable care organization, they could CMMI would encourage on a voluntary basis a thoracic health program that would and the rationale would be that would improve the whole ACO's outcomes.
part of that could be they have to do it the way Mary just, in order to qualify for that payment, you need to set up a program like Mary just said, because it works, it's a standard of care. Would that be part of it as well?
It could be that a lot of details have to be
Sure.
worked out. That's certainly
Okay.
one approach, and the way CMS has done some things is, if you do it real aggressively, they'll give you more money. If less aggressively, less money. Sort of to get something going
Right.
like that, to make it flexible. So I agree. Well, it won't work every place,
Right.
but some elements of this could work
In some places, right?
in a lot of places. Yeah, I think. So
There is a question. I don't know if you want to continue on and then we'll
Yeah.
go back to the question.
no, let's
Okay.
let's see.
So Elizabeth Estes says, has there been a white paper done on this, talking about our model? If so, where can I find it? The concepts of showing the inefficient manner of how the follow-ups are done would be great for learning to learn from other people in other institutions. It reminds me of a study done at UCSF regarding treatment of diabetes. And then the savings for the system and the better care provided to patients would be a new system for the nurses and PCPs making the decisions. I totally agree. There hasn't been a white paper on this, but there has been a lot of work about a centralized model has better adherence, better follow-ups, but this is even adding more to that. And I think if we're one hospital system with one nurse practitioner, one and a half, and a coordinator, and just really like-minded people coming back together to think about all of this. But I think you can develop good structures in place in order to do this, no matter kind of what hospital system. But you have to build the structure as you're thinking about it. When you kind of go back and try to do it, it's a little bit more difficult.
Can I ask?
Yes. Oh, there you are. Thank you.
Yeah, interesting. UCSF did something with diabetes, and the way they figured it out wasn't how you did it, which was real time. They actually used big data. They used bioinformatics and went through the EMRs and figure out how everybody was being treated there. It would be interesting, since you're at U of I, to get someone in the bioinformatics department to say, let's look prior to us starting this, how many different people they saw, how many different paths they took. I mean, you could almost do it with big data to do a white paper to prove the model. I think it's brilliant. And I think it's a really smart model.
I love that. All right, I have another project in my back pocket.
Sorry.
Oh, it's all good. It's all good. I mean, this really kind of, my model really kind of grew organically. And I would get grants and I would get a person to help me out. And then I was able to show leadership, like with an extra person, with this, we can do more, we can do better, we can, and that kind of really revolutionized how we did it, with really keeping the patient at the center.
And what did you have to show, Mary? What was it that you were trying to show? You said you were tracking and you were, who were you showing these results to? And what was the metric that they looked at?
Yeah, so we were looking at all of the scans and how many patients were coming in on a monthly basis. And one of the big things is I was able to, radiology was supposed to be scheduling the scans. So a patient, if they come through pulmonary or oncology, well, they wouldn't come through oncology, but some clinics will go ahead when you're leave, go ahead and schedule that scan. The majority of the time, when you see a primary care doctor, they said, I ordered the low-dose CT scan, schedule it when you can, which is a barrier to a lot of people. Now that they have to make a phone call, they gotta figure things out, and they weren't calling back. So our amount of scans that were being ordered, but nobody calling back to schedule. So then I decided to take that piece away, hired a scheduler to just call all those patients to schedule that. So we're taking away that barrier. And I was able to improve our lung volume significantly, because if you don't have patients coming back, you're not going to catch those lung red or those early stage lung cancers. If you aren't calling the patients after a year of follow-up and then trying to figure things out, then you have 18 months or 24 months in between scans where that doubling time comes in for those. Now you have a stage 3 cancer instead of a stage 1. And by talking to the leadership about that, then I have a full-time coordinator. So right when that lung cancer screening is ordered, she actually reaches out to the patient. She knows all about lung screening. She can answer their questions. And also something a little different with our patients having a lot of barriers to care. We also have a grant that covers Uber Health for them to come in to get scanned. We've already provided 300 rides to get patients in for their scans, or if they need a PET CT or a biopsy. So we're and I know that a lot of organizations can't do that. I did it under a grant, but it is a proof of concept of, by paying for $5,000 worth of transportation costs really increases your volume of patients coming back and all the care that needs to be done. Leadership needs to look at the economic models too.
Yeah. I mean, it's wonderful that your leadership looked at enrollment as a metric.
Enrollment is one thing, but also we're looking at the downstream revenue of how many patients were diagnosed. I mean, we have about a 3% diagnosis rate versus a lot of times it's in the 1s or 2% for a lot of institutions. And of course, we work at probably the highest risk was mainly African American that has the highest incidence and mortality from lung cancer.
And Bruce, what is it you're dreaming of with the metric that people are going to use, that Medicare is going to use to say this is really good? What were you thinking?
Well,
That we'd increase volume of patients, like Mary was suggesting,
Or the
that we
number of
would
cancers.
save them, what we would save Medicare money.
I lived in the world of administrative data,
Yeah,
and that's
this is Bruce.
as I think Elizabeth was alluding to bioinformatics. The administrative data is ugly in all sorts of ways, but it's easy to work with, and it's universal and it's there. And so what I've argued for is a yield metric that says of the incident lung cancers, what portion of them came through screening? And that's a very primitive measure, but if it came through screening, there's some stage shift going on.
Okay.
And it'd be fancier if we said, well, what portion stage 1, stage 2, stage 3, that multiplies the complexity
Yeah, but this
20-fold.
That's the lung cancer part. You're building something way beyond lung cancer here, right?
Well,
So,
and keep in mind, it's in the context of existing accountable care, which operates under budgets. So today, Medicare Advantage plans are providing transportation benefits and things like that. And
are you going to make a model for what's doing well? I understand the one you're recommending for lung cancer, but you're trying to build something for cardiac or osteoporosis, all these things. You're going to have a measure for each of them? Is that what I'm asking? I'm not suggesting.
you can, or
What are you thinking of in this model you're building?
I'm thinking that lung cancer drives it, and the other things are there because they're important.
Let me make one more point with leadership. In 2022, we had 22% of our lung cancers diagnosed and at our hospital was through the lung screening program. So they know that a robust screening program that is well run increases the, I mean, patients are in our population are going to get lung cancer no matter what.
Right.
If we screen them, we can improve outcomes, improve lives.
It'll be less costly.
And less costly. But I like where Bruce is going with this, because why can't our program take a look at the coronary artery calcification and the emphysema to be sure that they're in care? It's not just, did they get this biopsy or did they get this follow-up for lung cancer? But can we drill down to improve osteoporosis? Can we improve those outcomes? I might not be managing it, but we're following up to be sure that they're into care. Just a thought.
It sounds like that's what this is all about. I mean, it sounds like this is more comprehensive. That's why I don't want to say surprised, but because I'm sure you have good reason. That you're just focusing on the lung cancer metric for this.
I
It sounds like you
haven't
want to-
thought of the other metrics, and, you know.
Well, probably the same thing. I mean, almost the same thing. How many had osteoporosis that, I mean, yours is your metric is a quality though, right? It's not a metric of money, it's a quality metric. We know finding osteoporosis is good. How many patients did you,
Walk to the hotel.
we're treated for osteoporosis now because, through screening. How many patients were treated for their heart disease because of
Screening.
something, the exact analogy.
I think there's analogies. The difference is that there's already lots of patients in the system for osteoporosis, and we want this to be a population measure.
But so what?
So with lung cancer, that's a well-defined population that should come through screening. And most,
Osteoporosis, the same thing.
well, there's other existing screening programs as well, cholesterol measurement is ubiquitous.
Yeah.
And, so a lot of the high-risk people, blood pressure is ubiquitous, right? So a lot of people with at risk for CAD are already identified in the system. And that's, as we know, that's not the case with lung cancer.
Just such a threshold to go.
You're right.
But yeah,
You're right.
you have to
But
come up with
I
some.
have to think about that. Let's see, we're coming close to the end of the hour. So one more slide, and then I'm gonna ask for what kind of dog are we creating? So, so a next step, since Barry volunteered for homework, is to translate the populations of the programs and CPT codes, OPPS codes, other kinds of codes and put price tags on them and create a model of how many people are we really talking about, and what's the accountability for services, what's the accountability for money, and with that, any guesses on what kind of dog we're creating?
Elizabeth, give us a guess of the dog.
What's Sutherland White Terrier?
I'm saying a West Highland White because they get pulmonary fibrosis, so if all you have to do, everything looks like a nail, so I want.
Biased.
Very close. Anybody else?
Some kind of terrier.
Scotty.
I have terrier in mind.
Okay,
Wire hair,
let's go to
wire
the
hair
next
fox terrier.
slide.
Oh, we're gonna find out.
We might have a couple. Okay, gotta skip over. We know this.
Oh,
Yeah.
yeah, sorry.
Okay. Oh, we know this too. Tail of the dog, outcomes.
Going.
Man, I have too
Oh,
many
no.
slides.
Gotta start barking.
Ah,
Ah,
carrier.
Yes. Well, thank you all very much. It's a lively discussion. Now, we're going to, I think, write up a summary of this concept, and Bo gets to present it tomorrow along with Jim.
I'm gonna defer to one of you all.
We vote for Bo.
I may be on. the
I'm voting
agenda,
Bo.
but,
the West Highland White Terrier.
But
Yes.
thank you.
Bye, guys.
Thank-
Bye.